syndrome versus disease then, right? So if it's coming from an adenoma, right? Or if it's coming from some type of neoplasm that's found in the anterior pituitary, forcing the adrenal gland to secrete cortisol, that is disease. Anything else, syndrome. Coming from a lung cell carcinoma, syndrome. Coming from taking too much steroids, syndrome. Coming from a carcinoma of the adrenal gland, syndrome. Very easy. I would have to agree with you on that. Okay. One more time. So if you have Cushing's, it's either disease or syndrome. If the source of your Cushing's is an anterior pituitary tumor, it's disease. If it's anything else, it's syndrome. Perfect. All right. So let's remember what cortisol does. Cortisol is important for helping to maintain your blood glucose levels constant, really by working through gluconeogenesis, right? It helps in increasing your blood pressure. It helps in inhibiting inflammation and depressing the immune system. So that already tells us some of the symptoms associated with having too much cortisol already, right? If one of the manifestations of secreting cortisol is increasing your gluconeogenesis, then people with excess cortisol will have excess blood glucose levels, right? If cortisol is important for increasing the action of vasoconstrictors, people with excess cortisol will end up with hypertension. Does that kind of make sense, guys? So typically, when you're thinking of the manifestations associated with exaggerated effects of cortisol, you are going to think about manifestations like hypertension and weight gain. So hypertension and weight gain are usually the very early manifestations that you'll see. Usually the manifestations develop gradually, but if it's something like a small cell carcinoma of the lung, that tends to be an exception. The Cushing's develops pretty rapidly like that, but more times than none, that's not the reasons for your Cushing's. So you have more of like a slower gradual manifestations, but the patients will start to gain weight. They'll be hypertensive. After a while, more and more adipose tissue becomes apparent. They get what's called the moon face. So you can see how this little boy, his face is really more it's more moon-like, right? Like a full moon. They get a lot of truncal obesity, as you can see right here. And they also accumulate what's called fat on the back of the neck or the cervical region. This is known as the buffalo hump. Overall, when you're thinking about increases in cortisol, it tends to slow down your metabolic function. Actually, it almost nearly disables it, hence this severe increase in adipose tissue, right? Another thing that you'll tend to see are these striae. So these striae that you see right here are basically like stretch marks, okay? The skin becomes very thin and very fragile. The collagen begins to decrease in the patients who have Cushing's, and as a result, they get these purple striae and their skin is very easily bruised. So you'll see the moon face, you see the truncal obesity, the purple striae. Those are very common when you come on to symptoms associated with Cushing's. There's a lot of protein wasting. The muscles begin to atrophy. There's a lot of thin wasting, not thin, there's a lot of wasting away of the bones as well. The bones begin to demineralize. Now, that usually comes from the fact that the collagen is decreased when patients have this excess cortisol. So when you're thinking about the manifestations, just start thinking about the fact that, you know, the pressure is going to be high in these patients. The glucose levels are going to be high. So you'll see like hyperglycemia, glucose intolerance, hypertension. The collagen begins to decrease. So you'll see the demineralizations of the bones. And eventually osteoporosis. You'll see they'll have the purple striae due to that decrease in the collagen. And if you notice, your start products of cortisol and androgens are actually similar starting products. So sometimes when you have these excess increase in cortisol, you start to see an increase in androgens. So the patients tend to have a lot of acne, menstrual irregularities. The women tend to have a lot of excess hair production. right? One thing you may notice, like let's say, you know someone that has some kind of long-term inflammatory disorder or disease like RA or OA, like osteoarthritis or rheumatoid arthritis, they're at risk for things like osteoporosis due to the fact that the excess steroids can demineralize the bones. So, these are just examples of some clinical manifestations associated with Cushing's. So let's say, for example, you want to identify what is causing the Cushing's. So it's easy to identify if it's coming from an exogenous source like, excess steroids, because you'll know if someone's taking excess steroids, right? You get that from their patient history. But what if you suspect that it's Cushing's disease, but you're unsure, okay? You suspect it's coming from some type of tumor, but you're not sure where the tumor is coming from or where the tumor is located. You could do what's called a dexamethasone test, which is usually helps you to distinguish patients with excess production of ACTH to see if it's due to a pituitary adenoma or due to some kind of ectopic ACTH producing tumor. So maybe something coming from the lungs. So the whole idea is this. The patients are given dexamethasone, which is basically a synthetic glucocorticoid, right? So it's like synthetic cortisol. And they're given it every day for about 4 days. In the first 2 days, they give these low doses of dexamethasone. And in the last 2 days, they give high doses of dexamethasone. And then they collect the urine and blood of the patients to test for levels of cortisol, okay? So the idea is if you give these low doses of dexamethasone, what you're really trying to do is you're trying to establish some kind of baseline, right? To see, if you're to try to see the baseline of how much cortisol the patient has in the blood. If you give a low dose of the dexamethasone, okay, due to the fact that the body is already producing so much ACTH, the cortisol levels are going to be high anyway. So nothing really different is expected to happen to those patients. But in the last 2 days, when you do the super high dose, the idea is that you want to try to trick the pituitary if it's working properly. So when you give these extreme high doses of steroids, the pituitary, which would normally, if it's producing excess ACTH in Cushing's disease, the pituitary would actually start to respond by negative feedback and decrease how much ACTH it's giving off. So it's gonna respond, but it needs like this ridiculously high dose to respond. If that is the case, and you see it decreasing its ACTH levels, that's telling us that the patient actually does have Cushing's disease, because you're able to manipulate the levels of cortisol in the blood by forcing the pituitary to respond. Now, let's say, for example, it was coming from a lung carcinoma. No matter how much cortisol you give this person, no matter how much dexamethasone you give, no matter how high the dose is, that tumor will not respond by negative feedback because it's not a part of the negative feedback loop. So that will solidify to you that no matter how high a dose of dexamethasone you give, you cannot manipulate the levels of cortisol to be decreased in the blood, which tells us that what's forcing cortisol to be high is coming from an exogenous source, not a source that's on the actual pituitary pathway. So that's one way that you can distinguish between whether or not the person has a Cushing's disease or they've got ACTH being secreted by some kind of exogenous source outside of the actual pituitary gland. So, really when they do this dexamethasone test, their idea is that cancer cells don't respond to the feedback control. So if it's an ectopic tumor, ACTH produces, like if it's an ectopic ACTH producing tumor, nothing will change. So the clinical differences between the syndrome and disease, there's no real clinical manifestations difference. It really lies between what is causing the levels of cortisol to increase. Exactly, Dan. So that's exactly where it's coming from. And you need to be able to figure out where that source is. And one way you can figure out that source is doing the dexamethasone test. So if someone has Cushing's, you kind of want to figure out why, and then you treat them based on the etiology. So if it's due to some exogenous source, like long-term steroid use, you'd have to withdraw the steroid. If it's due to a pituitary adenoma, you either have to do radiation to shrink the tumor or remove the tumor itself. If it's due to an adrenal tumor, you'd want to remove the adrenal tumor, right? But the whole idea is you want to decrease the what's causing for this increase in cholesterol, in cortisol to occur. Okay, any questions on that? Okay, so what about hyperaldosteronism? All right, so typically we're talking about either having too much aldosterone coming from the actual adrenal gland, or too much aldosterone coming from something forcing the renin pathway to increase your aldosterone. So remember, it is not the pituitary that's telling the adrenal gland to release aldosterone. It's things like increase in potassium, decrease in sodium, changes in the blood pressure. Okay, so when someone has hyperaldosteronism, if they have it due to the fact that they've got some kind of tumor in the adrenal gland secreting aldosterone, that's primary and it's known as Conn syndrome. If you have a secondary hyperaldosteronism, it's usually something associated with poor kidney perfusion. So for example, if a patient has heart failure, right, that means they're not able to have enough cardiac output to supply the body, which means that when the blood flows through the kidneys, blood perfusion is going to be low, which means the kidneys are going to secrete renin, which means renin is going to activate the renin pathway, which means that aldosterone is going to be increased in an individual with that low perfusion. Does that kind of make sense, guys? So in a secondary hyperaldosteronism, it could be because of heart failure. It could be because there's not enough blood perfusing through the kidneys. It could be because a patient has liver cirrhosis. So, circulation is decreased. And once circulation is decreased, the renin pathway is going to go into overdrive. So let me ask you guys a question. If somebody has a primary hyperaldosteronism, do you expect the renin pathway to be low or to be increased? Or what do you think? If it's a primary Conn syndrome, the renin pathway would be elevated or decreased? It would be decreased, right? Because if you have a tumor secreting aldosterone, negative feedback is going to send a message to the pathway saying, hello, we don't need you right now. Very good. But if it's secondary, will you expect the renin pathway to be elevated or decreased? It would definitely be elevated. Absolutely. Okay, you guys are right on track. Very good. All right, so remember, what's the job of aldosterone? To increase your sodium and decrease your potassium levels. So if you have a situation where you have an increase in aldosterone, what's going to be your manifestations? Increase in aldosterone means increase in sodium, which means increase in water retention, which means what? Increase in blood pressure. Does that make sense, guys? Okay. Also, when you've got high aldosterone, you have too much sodium coming back and you start to waste potassium, right? And a low potassium can cause a drop in your heart rate, really slow your heart down. Patients may be feeling lightheaded. They may have like tingling or like skipped heartbeat kind of feeling. So that would be how it would manifest. Like your Conn syndrome is going to manifest as hypertension and potassium loss. Does that make sense, guys? Okay, so what about hypoaldosteronism? Okay, what do you think? Well, so how would someone manifest with, so this is a really good question, Dan. You have to, it does seem like it would be counteractive, but you have to think about what's causing the situation to occur. It's coming from two different type of aspects. So the hypertension is coming from, not from the fact that the heart is beating too fast. The hypertension is coming from too much blood volume. The slow heart rate is coming from the fact that the potassium levels are low. So sodium and potassium are important for your regulating your actual action potentials for the heart to contract. which causes for the slow heart rate. Because remember, the low potassium is what's going to cause, yeah. So the patient's blood will be thicker. No. The blood is not thicker. You just have more fluid in the blood, more volume, like, because you're bringing back water. So it's more volume. It's literally more volume of blood. You can get on the mic, Justine, for sure.
Okay. Okay. Thank you, Professor. So low potassium so it's hypertension and there's low potassium. But since there's hypertension and there's more pressure within like the blood vessels, wouldn't I thought potassium since there's so much like sodium within the body, like wouldn't that make your heart beat faster and potassium would actually slow it down? But if there's low potassium, wouldn't it, like the heart would still continue to beat fast, right? That's the only part that's really confusing me right now.
Well, that's because you guys are trying to put the hypertension and the you're trying to put the hypertension with the heart rate. It's two different things. The hypertension is coming from the blood volume. The slow heart rate is coming from the fact that when you bring back sodium, you waste potassium in the urine, which means that there's not enough potassium in the blood. So a drop in the levels of potassium is going to affect your nervous system impulses. And how does your heart contract? Via nervous system impulses. So if you can't generate a nerve impulse because you've got this low potassium, what's going to end up happening is you won't be able to generate contractility of the heart. So there's two completely different pathways. Does that make sense?
Yeah, kind of.
So Ryan is asking a good question as well. The low potassium, would it affect the skeletal muscle contractions? Absolutely. The low potassium is going to make the skeletal muscles weak, just like how it's making the heart muscles weak.
Okay, I get it now.
Very good. Yeah. Yeah. So it's not about the cardiovascular system. It's about the nervous system telling the cardiovascular system what to do.
So we think in the concept of the nervous system, not cardiovascular. No, don't think of the like other part of the storybook that could cause a whole bunch of other problems. Just think of the main story that you're reading, basically.
It's not about the main story or another story. It's about thinking about the pathway. So hypertension can be because of, so in this case, the reason that the patient has hypertension is not because the heart is contracting too fast. It's because they're retaining too much fluid. So that's from a volume standpoint, right? The low and slow heart rate is coming from the hypokalemia. So it's two completely different pathways.
Okay, I understand it.
Yeah, so Andrew is saying the hypokalemia prevents the depolarization of the cells. Exactly. The hypokalemia is really due to the fact that you just don't have enough potassium, and it's causing for you to just not generate this nerve impulses at all, or very, very little nerve impulses. So low potassium does things like slow down your GI tract, slow down your heart rate, slow down your skeletal muscle contractions. It's slowing down these contractions, right? So when you're thinking about the hypokalemia, think about slowing down these contractions due to the fact that the nervous system is not being triggered enough. It's decreasing your nervous system response. So just like, you know, when you watch the movies, I mean, they don't do this in movies anymore, but I remember when I used to watch, so growing up, right? I would watch a lot of like soap operas, because I don't know why I used to do that. Probably because, you know, I didn't have cable growing up. So I used to have to watch local TV, and that's what came on local TV. But all the time in the soap operas, they try to kill people. And you know how they try to kill them? They inject them with potassium. Why? Because they want to slow down the heart rate and stop it. I mean, that's a really bad example. But like,
that was a really bad.
I don't know, but that's what comes to my mind. But you guys get the concept though, right? That is two completely different pathways, the hypertension and the hypokalemia. Okay. So, Lord, you guys bring out the worst in me. So what about if someone has hypoaldosteronism? Why would someone not be making enough aldosterone? What do you guys think? because there's too much sodium. All right. What about if there's like kidney failure? If there's kidney failure, the renin is depleted, right? Maybe there's some kind of tumor, right? Okay. But typically when you have tumors, then they usually cause an increase in the hormones to be secreted, not a decrease in the hormones to be secreted. Okay, so Andrew raises a good point here. Do you think it's a pituitary problem with ACTH? Because ACTH don't have anything to do with the pathway for aldosterone. The pathway for aldosterone comes from the renin stimulation. Yeah. Okay. All right. So if you have hyperaldosteronism, right? Aldosterone is what brings back your salt and water, right? And causes for your potassium to be excreted. So essentially, if you have a hyperaldosteronism, okay, what would be your clear number one manifestation is going to be hypertension for sure, because of all of that bringing back of your salt and your water. And then you would want to restrict your salt. You would want to replace the potassium, right? And you want to decrease the fluid levels in the body. Does that kind of make sense? Perfect. Okay, so let's go into the adrenal medulla. The adrenal medulla, right, is basically a knot of sympathetic nervous system, and very rarely you will have a tumor there. And if you do have a tumor, what it's going to do is it's going to secrete catecholamines like crazy. It's going to be this excess increase in catecholamine secretion, right? And what all that leads to is increase in your epinephrine and norepinephrine. What do you think is going to happen if you have such high levels of catecholamine circulating in the blood? What do you think that's going to do for your blood pressure? It's going to increase your blood pressure, right? So the number one manifestation of pheochromocytoma, which is having that tumor, which causes for that excess secretion within the adrenal medulla, is going to be your high blood pressure. So hypertension is the number one manifestation associated with this disorder. So typically, when you're thinking about this increase in your catecholamines, the patients are going to have like headache, they're going to be hypertensive, they'll have palpitations, they'll have like sweating all the time, they'll be flushed, they'll be nauseous, they'll be losing weight like crazy, right? Yeah. And all of that is associated with the increase in the catecholamines. Listen, you hear my little killer out there barking? Good Lord, she needs to stop. Well, the symptoms are going to be very general, Jason, because if you think about it, how does your sympathetic nervous system work? It's a very widespread nervous system, right? And what do your catecholamines do? Increase your epinephrine and norepinephrine, and that's going to trigger your sympathetic nervous system. So your symptoms are going to be extremely widespread. Yeah. Okay, so how would you clinically differentiate between pheochromocytoma and Graves? Well, lots of different ways. All right. So the first thing you would think about, Andrew, is with Graves, you're probably going to see the exophthalmos. That's the first thing, right? Yeah, right. Definitely. That would definitely be the first thing that you would see for sure. And then after that, you major giveaway, right? And then after that, you would test for your TSH levels. Because more than likely, when someone comes in and they've got symptoms like this, you're not going to think pheochromocytoma. You're going to think hyperthyroidism. So you already test for your TSH levels, because pheochromocytoma is so much more rare, and Graves is so much more common. But the exophthalmos is really a dead giveaway. Okay, so how would you determine what's going on? Typically, you do like a CT scan, right? And you would want to, I would say, remove the tumor, as that would be the only way to really cure the pheochromocytoma, right? And then in the meantime, you want to manage the blood pressure, okay? So you'd obviously take medication to block the sympathetic nervous system, and that will help to decrease the overall blood pressure. All right. Everybody's okay with that one? Let me go into your web courses a second. I want to see something. Class is this. Patho 2. There's this really awesome video. I don't know if it's released yet. What's today's date, guys? Oh no, it's delayed. It's gonna be it's gonna be released tomorrow. Okay. So come tomorrow, you're gonna see this really awesome video. It's gonna be released tomorrow, and it's a video on the parathyroid gland disorders, and it's the most brilliant thing. Like sometimes when I teach this class, I feel like, why do I have to even teach the parathyroid gland disorders? Because this video does such a better job than I do. Okay, but you guys should be sure to watch that video when it does get released tomorrow. So the tumor on the adrenal gland is how you would differentiate it from Graves. I missed how we differentiate the two. Well, okay, Shannon, you have to think about that. No one's really signing you up for a CT scan or an MRI that easily because it's very expensive, right? Okay, so what you would do is you would, more than likely, you would think the patient has a hyperthyroidism. So you probably test for the TSH levels and the T4 levels. That's the first thing you could do. That's very easy. But if you suspect, if like say you do that and your tests come back negative for hyperthyroidism, then you could possibly do the CT scan and look for the adrenal gland tumor, adrenal medulla tumor. Yeah. But like Andrew is saying, right, the exophthalma for sure is going to be one of the dead giveaways if they come in with Graves' disease. Like you're not going to miss that wide-eyed stare. All right. So when you have a parathyroid gland disorder, right? First of all, let's think about what the parathyroid gland does. The parathyroid gland is important for increasing your calcium levels in the blood. How does it do this? It goes to your bones and it tells your osteoclast to eat away at the bone and bring calcium back into the blood. It goes to your kidneys and it tells your kidneys to reabsorb calcium. It goes to the gut and tells the GI tract to make sure it absorbs lots of calcium that day. It tells your kidneys to release vitamin D, activated vitamin D, so that you can utilize that calcitrol and bring back as much calcium as possible, okay? So parathyroid hormone is all about increasing your calcium levels and decreasing your phosphate levels. That's really what it is all about, all right? So remember, anytime your calcium levels get low in the blood, parathyroid hormone is increased, released from the parathyroid gland, goes to your bones, tells your osteoclast to eat away at the bone. So what do you think is going to happen if you've got too much parathyroid hormone? What's that going to do for your bone? What do you think? Osteoporosis for sure, right? It also goes to your kidneys and tells your kidneys to reabsorb calcium as much as possible. But I have a question for you. What are you going to think is going to happen when all that high calcium blood comes through the kidneys on a daily basis? What do you think that puts the patient at risk for? All that calcium in the blood. Not just kidney disease, but what kidney stones, exactly, Vincent. Very good. And then it also goes to the GI tract and says, you know, bring back a whole bunch of calcium, right? The idea is to try to increase calcium in the blood as much as possible. So these osteoclasts, they're out there eating away at the bone, right? And trying to increase your calcium levels in the blood again. So essentially, everybody's working to increase your calcium levels. But if your parathyroid gland releases too much parathyroid hormone, maybe because you had a tumor on the parathyroid gland, that parathyroid hormone is in excess, your bones begin to degrade away, right? Your kidneys are at risk for kidney stones. And then your calcium is really important in regulating so much the nervous system, the GI tract, you know, the musculoskeletal system as well. So you'll start to see symptoms associated with that. So remember, PTH increases your calcium levels, but calcitonin, right, tells your calcium to go back into the bone. But because the PTH levels are so high, calcitonin can't work hard enough to deposit calcium back into the bone if you've got some kind of tumor that's causing the parathyroid gland to secrete excess parathyroid hormone. So when someone suffers from hyperparathyroidism, it's either primary or secondary. All right. So let's think about this a second. If it's primary, you probably have some kind of tumor on the gland, on the parathyroid gland, and now it's secreting too much parathyroid hormone, which means I have too much calcium in the blood, which means I don't have enough phosphorus in the blood as well. Too much calcium in the blood affects the nervous system and the kidneys, as we just discussed. Does that kind of make sense, guys? Okay, so what about a secondary hyperparathyroidism? What would cause you to have a secondary hyperparathyroidism? Well, let's think about kidney failure. If you have kidney failure, you can't activate vitamin D. If you can't activate vitamin D, you can't absorb calcium. If you can't absorb calcium, calcium is low in the blood, hypocalcemia. That's going to be chronic because you have kidney failure. So because of that low calcium in the blood, long term, the parathyroid glands start increasing their parathyroid hormone secretion in an attempt to try to increase your calcium levels in the blood. Does that make sense? Yeah. So anything like a high phosphorus load or deficiencies in vitamin D would put you in a situation where it's secondary hyperparathyroidism. So the way you can remember what happens with your parathyroid glands go into overdrive is the stones, bones, groans, and moans. Would it be fair to say most secondary hyperparathyroidism to chronic kidney? I would say so, Dan. I mean, some of it can be due to the fact that you've got high phosphorus, but most of the time it coming from the fact that, your kidneys are screwed up and you can't activate the vitamin D for sure for secondary. However, more commonly is going to be primary, where you have that tumor on the parathyroid gland leading to the excess parathyroid hormone. So typically what is going to manifest is the stones, bones, groans, and moans. So the stones would be the kidney stones, right? The bones would be all the bone related complications, right? The painful bones because of bone breakdown, the lesions on the bones itself. The abdominal groans come from the fact that there is a lot of constipation associated with high calcium levels. There is, when you think about hypercalcemia, you would think about nausea because hypercalcemia increases acidity in the stomach, triggering like loss of appetite, nausea, vomiting, and something else. So hypercalcemia also makes the kidneys, it's hard for the kidneys to concentrate the urine. So patients lose a lot of sodium in their urine, and water follows sodium. So they become very dehydrated. Central nervous system gets affected because the calcium is important for neural triggers, right? So patients are like lethargic. They may even suffer from seizures as well. What else can I think of? Oh, pains, right? Pains from the fractures of the bones, from the osteoporosis, maybe pain from the kidney stones. So that's your stones, your bones, your moans, and your groans. Okay. Oh, how could I forget? Peptic ulcers. When you have hypercalcemia, you have too much acid being triggered in the GI tract. So not just nausea, right? But peptic ulcers as well. So your clinical manifestations could be anything from kidney stones to demineralization of the bones to the dehydration and polyuria that I described, right? And then calcium affects the nervous system. So you're going to be looking at things like, cardiovascular, not cardiovascular, but heart contractions being slowed down. Patients could go into cardiac arrest or even have like heart block. The good thing is that it's very easy to treat. And something else is that when you guys get blood work done, you know what's checked routinely in your blood work? Your calcium levels. So hyperparathyroidism tends to be caught early because once you check your blood calcium levels, they'll be able to see that it's too high. Essentially though, there's no pills you could take. you have to basically do surgery to remove the parathyroid gland that's causing for the excess parathyroid hormone secretion. And the cool thing is once it's removed, you're pretty much immediately cured, right? You have the manifestations just start to revert almost immediately. Because remember, your bones regenerate very well, right? And once the osteoclasts stop eating away at the bone, the osteoblasts will begin to lay down new bone within the next few days. And your calcium levels will just start to fall very quickly after you remove the tumor. And it's going to be very beneficial to the patient once they remove the tumor from the actual parathyroid gland. So patients who have contradictions for surgical correlations, they're just shit out of luck. Pretty much. I mean, you can dilute the calcium in the blood with some kind of like IV solutions. And you can probably try to use calcium, like loop diuretics to help increase your calcium excretion. But in terms of like inhibiting the bone resorption, you could probably try calcitonin to give calcitonin. But essentially, they're going to need to remove that tumor because that's the only really way to cure it. But yeah, essentially, they're probably a little bit out of luck, my friend. But because the only thing they can do from there is try to dilute out the blood calcium with the IV solutions, or maybe give a loop diuretic, help with that calcium secretion. But even, I mean, the massive amounts of calcitonin that you're gonna have to give them, that's gonna be for life. They're gonna have to outweigh the pros and cons, and it's not. And the good thing is that it's not like major surgery. It's an outpatient procedure, really quick, maybe like 30 minutes. So it's not like a major surgery. Okay, so what about hypoparathyroidism? Okay, well, in this case, what's happening here? You are not secreting enough parathyroid hormone. Okay, so your parathyroid hormone is decreased. Okay, it could be due to the fact that maybe you've got some type of, I don't know, autoimmune disorder attacking the parathyroid, maybe some kind of infection attacking the parathyroid gland, or you remove your thyroid and screwed up your parathyroids in the process when you were removing a piece of your thyroid. So you would have a primary or secondary, just like we've always seen before. Okay, so I guess if the example of the removal of the thyroid, which causes your parathyroids to get screwed up, that would be a secondary. So, primary would be a congenital lack of parathyroid tissue. That would definitely be a primary hypoparathyroidism, or if you have some kind of autoimmune process targeting or damaging the parathyroid glands. So what happens now? Now you've got a low calcium levels in the blood. And like we talked about before, calcium is important for muscle contractions and nervous impulses. So typically when the calcium is low, right, it causes for increased action potentials because your threshold, remember how your action potentials, right, you have to get to the threshold in order for the action potential to occur. Well, low calcium gives permeability to the neurons, right? And it causes for less excitation to be required for you to get to the action potential. So patients are going to be spasming a lot. They'll have spasms in the hand, they'll have spasms in the larynx, they'll have muscle spasm, lots of muscle cramping. And then one thing we'll learn about when we get to the seizure unit is that the reason why someone has a seizure is because the threshold is lower in the neurons and they just start firing like crazy in the brain. And that's what's happening to these patients, right? Calcium is lowering the threshold for the nerve impulse. And then as a result, like they just have this excessive firing in the neurons, which causes for the seizures to occur. So in a situation like this, you would have to administer like an activated form of vitamin D, right? You administer the calcitrol and try to increase the calcium in the blood, give calcium supplementation with vitamin D in order to help to keep these patients' calcium levels high enough. Does that kind of make sense, guys? Cool. All right. So last but not least are the ADH disorders. So ADH is what? Vasopressin, right? These names are used interchangeably. Be aware of that. But what does ADH do? It brings back water, right? It's all about conserving water in the body, reducing the loss of water via the urine. So if you have diabetes insipidus, you have not enough ADH functioning. It could be because either you have a neurogenic diabetes insipidus, which would mean that the actual ADH is not being released from the brain. So that's neurogenic, right? Neuro means brain. Or it could be nephrogenic, meaning that the kidneys are not responding to the ADH. So no matter how much ADH I make, my kidney receptors are not responding to it. So I can't bring back water because my aquaporins are not being made. Okay. So I have a question for you guys, right? If you have syndrome, no, that's a lie. If you have diabetes insipidus, right? And you're losing copious liters and liters and liters of water, instead of losing about 1 liter of urine, you lose about 20 liters of urine a day. What is that going to do for your serum concentration of the blood? If you have sodium in the blood, you lose all of that water, your sodium concentration is now going to seem very high in the blood relative to how much water you have. So the patient starts suffering from like a hypernatremia. Does that kind of make sense? Okay, very good. So I have a question for you. My question is this: how can I tell if a patient is suffering from a neurogenic diabetes insipidus or a nephrogenic? Is there some kind of test that I can do functionally to see whether or not it's the ADH not being released or the kidneys not responding to the ADH? What could you do? Well, the urinalysis will only tell us that there's not enough ADH. You could administer the ADH and observe the effect. Exactly. Because if you administer ADH, right? So essentially what's going to happen is this: the patient is losing urine like crazy. They're losing so much fluid in excess, right? So if I administer ADH and the urine decreases in volume, this tells me that the receptors on the nephrons are working just fine. So the problem is coming from the fact that I don't physically have any ADH, because if I replace with synthetic vasopressin, it works, right? But if I give synthetic vasopressin and nothing happens, I still have copious amounts of urine. That tells us that the kidneys are what's screwed up, because no matter how much ADH I give, the kidneys are not responding. Okay, very good. All right. Well, you'd be really in a sad situation if your kidneys are screwed and your posterior pituitary are not working either. But I guess it could happen. But you would just be a really unfortunate individual. I mean, the likelihood of that happening is like slim to none, it being both. But it's usually one or the other, Jason. Man, you guys always go to like worst case scenario. Good Lord. So not a very positive group, are you? Man, come on, guys. But then again, this is not a very positive time. So syndrome of inappropriate ADH would mean that you're making too much ADH. So what happens if you make too much ADH, right? Typically, the most common cause of, having too much ADH usually comes from some kind of tumor that's ectopically secreting ADH. So, or you're taking some kind of drug that helps you to secrete too much ADH. But what would happen if you have too much ADH? What's going to happen, guys? Yeah, your blood pressure is going to be through the roof because your blood volume is going to be through the roof. Very good. And your urine output is going to be low. And what's going to happen to your sodium concentration relative to your volume? It's going to be what? Low, right? So you'd have a hyponatremia in this case. Absolutely. All right. Very good. Okay. So you don't have enough sodium in the body fluids. Oh, and then here's the deal. Your neurons are so crazy because in syndrome of inappropriate ADH, your neurons are going to swell because it's going to be collecting water. And then diabetes insipidus, your neurons are going to shrink because you're losing water. But whether a neuron swell or shrink, the manifestations are usually the same. So you can see that in the manifestations, right? For both of them, it's, things like seizures or disorientation, confusion, coma, they're going to be pretty common between both of them because whether the neurons shrink or swell, it still gives the same effect. So remember, don't mix up aldosterone with ADH. Aldosterone is your saltwater hormone. ADH is your tap water hormone. But like you guys already mentioned, if you have diabetes insipidus, you're going to have polyuria, too much urine, leading to dehydration, which would cause for polydipsia, which is a lot of thirst. Your urine specific gravity is going to be low. That just means that your urine is too dilute. You've lost a lot of water. So you've got a hypernatremia due to your water deficits. Everything is dehydrated. Dry mucous membranes, decreased saliva, decreased sweat production, and then of course the neurological effects that we just talked about. In syndrome of inappropriate ADH, you'd have a hyponatremia. You'd be retaining so much water that your urine osmolarity is very high. Urine is very concentrated, but your blood osmolarity is going to be very low because your blood is going to be too dilute. All your cells are going to swell. You're going to have a lot of muscle cramping and, blood pressure increasing and, the neurological symptoms like we talked about before. Does that kind of make sense, guys? Cool. So how would you treat it? Well, with diabetes insipidus, you want to replace the ADH. You want to make sure they have access to fluids, right? With syndrome of inappropriate ADH, you want to restrict access to fluids. You want to correct the hyponatremia as best as possible, okay? And, you could also, you could also be giving diuretics to pull that fluid off of the body. Okay. Any questions on that?
I don't have a question on that, but I was just wondering if you could possibly go over the syndrome and disease slide again, just like the examples you were saying before, because it's kind of like not.
For which one?
When you were talking about syndromes or like, oh, is this a syndrome or would this be a disease?
Oh, you mean for Cushing's?
Yes, I was kind of like a little bit confused.
Okay, so the easiest way to remember it is this, Leandro. If the patient has Cushing's, it's going to present the same way, regardless of whether it's disease or syndrome. If they have Cushing's because there is a tumor on their anterior pituitary, it's disease. Anything else, it's syndrome.
Got it.
Yeah. Any other questions, guys? All right. Okay. Well, it's not too bad, right? My advice to you guys would be this, like I always tell you, think about the hormone, think about what it does, and then say, if I have too much of it, what happens? If I have too little of it, what happens? And I mean, I wouldn't go around trying to memorize all these clinical manifestations. That's just too hard. I would just start thinking about what the hormone does, and then I can just use my critical thinking skills to say, what if I have too much or too little? How is it going to manifest? One thing I will say though, is remember the names of the diseases, because I see students do things like mix these two up all the time. Syndrome of inappropriate ADH and diabetes insipidus, So remember diabetes insipidus, the one way you can remember it is diabetes means to overflow, right? So that's one way that you can, remember that you have the overflow of urine. So try not to mix up the names of the diseases. People mix up Graves and Hashimoto's all the time. Try to keep those straight. Specific drugs, like the names of the drugs themselves. Yeah, like you'd have to know the dexamethasone for the dexamethasone testing, because we spent a little bit of time on that specifically. But I mean, like I wouldn't necessarily say that you would have to know for a fact that lithium is used to block the effects of ADH in syndrome of inappropriate ADH. But now that I've said it, maybe you've got to know it. But, you know, just things like that. But like general effects, yeah. Anything else? All right. Well, you guys have a great rest of the day, great rest of the week. Stay out of trouble. Stay safe. And I will see you guys next week. Oh, you know why, Dan? Because literally I have about 700 emails and I'm really trying to work my way through them. When did you send me this email? Was it yesterday? Because I'm still on like Tuesday's emails, Monday's emails right now. Like it's so bad. People are emailing me out the wazoo. When I look at my little thing, you know how like when you look at your Microsoft Outlook, it tells you how many emails you have on read. I have 903 on read emails right now. 903. So I'm gonna email you. I just haven't gotten to your email yet, probably. But what you would, if you want, you could just send me, I know emails make me insane. You could send me another one. You want to just send it again? Because then that way it goes back to the top. Yeah, you might want to do that. Outweigh everyone else. But yeah, I'm working my way through these emails though. I really am. All right, guys. I will catch you next week. Take care.